Good evening, everyone, and welcome to the episode of Nearly with Nadira, Valvular Shock. And today is the first of the start on 2026, where we be. So, welcome everyone to the first episode of CBI Daily with Nadira. And it's truly a pleasure that today I have the world esteemed colleagues and friends joining me on this really hot topic of valvular shock. And let me introduce you to my panelists and speakers. So first we have Gennaro Giustino from New York. We have Pedro Villablanca. We have Dr. Bill O'Neill, and we have Dr. Konstantinos Voudris. And without further ado, we have a lineup of three very interesting cases. And we are really excited to share with you on valvular shock cases by these experts and discuss them among all of us. Without further ado, I'm going to hand over to Dr. Giustino to tell us more about valvular shock.
Thank you, Nadira, for having me. Yes, this is a topic that we are all very passionate about, and is the pure intersection between acute heart failure and structural heart disease. So I'm going to share my slides. Can you guys see them?
Yes.
Okay, so this is the concept. So in order to provide care for these patients, I think like the big domain of expertise rely on the ability to identify and characterize the hemodynamic status of your patients, mastering large bore access management. This is important both for providing mechanical cardiocirculatory support and for delivery of efficacy and effectively and safe of structural heart therapies. And the concept of structural shock relies, I believe, at the intersection between these three domains. And valvular shock is kind of like an underappreciated entity because most of the trials in cardiogenic shock, they're actually about ischemic cardiogenic shock. And valvular cardiogenic shock contraindicates and sometimes makes ineffective specific mechanical cardiocirculatory support devices. This is a very interesting study from the Cleveland Clinic that showed that in OLA, their CCU admission, about 16% of patients valvular cardiogenic shock, and this had a higher in-hospital mortality, particularly if these patients were not able to receive surgical or transcatheter therapy. But if they were having actually if they were treated with surgery or transcatheter therapy, they had actually much improved survival. And the problem for valvular shock is really the utilization of the appropriate device. And this is a great paper from Pedro from a few years ago, where he went through all the type of mechanical cardiocirculatory support to be used according to the underlying valvular lesion. And I'm going to talk a little bit about LAVA-ECMO, which is a strategy that we have been using. I learned at Henry Ford with Dr. O'Neill and Pedro, where we have been using this effectively in patients with cardiogenic shock from left side valvular lesions. This is a study we published in JSky last year, where we show that regardless of the underlying valvular lesion, particularly for the aortic valve or mitral valve with both stenosis and regurgitation, by placing the patient on LAVA-ECMO, which consists in a transeptal cannulation of the left atrium, you could achieve significant reduction in the left ventricular diastolic pressure, pulmonary capillary wedge pressure, and concomitant increase in the cardiac output index and provide oxygenation. So I'm going to show a case or two where this strategy could be particularly effective. So particularly hot topic. So we have a patient with a 75-year-old with a previous evolute to 29, presents in cardiogenic shock heart failure. I did this case a few months ago. Had a mixed flail of the non-coronary cusp and severe stenosis of the other two cusps. I placed the patient on LAVA-ECMO for stabilization and renal recovery, and then I did the CT for planning, which, as you can see, show high risk for coronary occlusion on the right side and possible increased risk for sinus sequestration on the left side. Therefore, I planned for on LAVA-ECMO leaflet modification and valve-in-valve tower. These are some of the steps for the LAVA-ECMO cannulation. After transeptal puncture, I perform a septostomy, either with a 10 or a 12 balloon, and then you can see the cannula that is placed in the left atrium on the right side. These are the baseline aortogram. You can see severe AI, and then the coronary ostium very close to the base. Here I start performing leaflet modification. In this case, I did a unicorn, first inflation. This is what the access point look like. On the left side, you can see a 22 dry seal and right femoral artery. You can see on the right side the LAVA cannula, the venous cannula that goes inside of the left atrium. And on the left groin, you can see the left femoral artery using for recirculation. In this case, I believe I use a 15 French arterial cannula, or you can use a 17 French arterial cannula. And for the venous cannula, I use a 21 French venous cannula. From the 22 dry seal, I did modification for both leaflets. So now you can see that I have a valvuloplasty balloon parked inside of the right cusp. And now I'm traversing the left cusp with an 8 French AL3 guide. And then finally, now I'm lacerating both leaflets with the valvuloplasty balloons inside of the evolutes. That's the waist on the left side. And that's the waist on the right side. And now the patient has wide open AI and is completely stable on support. And then from here, I go and with pretty prolonged rapid pace and do finally implant the valve. And the patient was decannulated at the end, and this patient was discharged alive from the hospital. So LAVA in this case serve as a bridge to get there to do leaflet modification and valve implantation. Let me show another case that Pedro and I and my former fellow Jonathan did when we were at Henry Ford, which is a pretty spectacular case. So this is a patient that 70-year-old woman, a prior surgical AVR and a surgical mitral valve replacement that presents in cardiogenic shock with severe AI, severe MS, and EF of 15%. You can appreciate on the wave, we published this case in Jack case report. You can appreciate from the waveform the very disturbed hemodynamics. And what we did, we placed the patient on LAVA-ECMO first. The PA pressure went down from 60s to 30s and the wedge from 36 to 4, just by placing the patient on support. You can have like pretty profound like decongestion and reduction in the pulmonary pressure with this. So after this, we stabilized the patient in CCU, then we got a CT scan. We planned then for a simultaneous valve-in-valve aortic and mitral. And you can and here are the steps of the procedure. A lot very busy, but you can see how all the ECMO cannulas are on the right groin, and then the sheath for delivery of the therapies are on the left groin, with sentinel on the right side, on the right radial, and a pigtail from the left radial. And then using on ECMO, we perform a valve-in-valve aortic first, including with and then a mitral valve-in-valve, including with fracture. And for the mitral, we just pull back the cannula in the IVC and then use the same ASD to perform the valve-in-valve. And again, this patient was decannulated at the end and was discharged alive. A couple of words, I think, in general management of valvular shock. This is something I've been implementing at Morristown, is just to try to have like structural to be consulted early when structural shock is identified. And I think the priority is really not different from ischemic shock, where you want to like go ahead fast and revascularize the patient. I think in structural shock, what you want to do is stabilize the patient and think what's going to be the best therapy. I've also used support to bridge the patient to surgery successfully. So you stabilize the patient, figure out what to do, get a CT scan, have a surgical consult, understand what's the substrate, and then deliver therapy on support. And then after you have addressed the underlying valvular lesion, you can de-escalate mechanical cardiocirculatory support. Thank you.
Thank you very much, Gennaro. That was a great presentation. I know the panelists have loads of questions. Anything, Pedro? Any comments would you like to make?
No, I think, Gennaro, this is great. I think, to me, this is actually a very hot topic within the leaflet modification groups about support versus no support. And, it changed my perspective for different reasons. TAVR in TAVR, as Gennaro is showing, or even surgical valves are going to come as an epidemic. And they're going to come in shock, a lot of them, right? So you don't want to be doing these procedures on a rescue basis where you lacerate and then expect the reaction of the heart. If it goes well, great. If it goes south, start rescuing with chest compressions and ECMO. Doing this almost like an elective high-risk PCI, with Impella, is almost the same concept. You want to do this on a calm fashion, controlled fashion, which can have you ready for all these possible scenarios, decompensation from the AI or the MR if you do a mitral case. And even more, people don't think about this. Let's say you do that you think successful laceration, but it ended up not being a successful one and you get an occlusion. Being on pump, it helps you to rescue that coronary with the stents, again, on a more calmly fashion. And the key, as Gennaro mentioned in the great case he did with the Evolute, you don't keep these patients sometimes on shock. You decanulate them very earlier, even during the same scenario in the next few days. So I think I'm happy that the East Coast with Gennaro there is getting all this concept and is being expanded because patients that were not eligible or were too sick are being treated right now.
Great. How about you, Dr. O'Neill, and your thoughts about it, followed by Dr. Voudris?
I could just make a quick comment. Nadira's Bill O'Neill. I'm incredibly proud to join you, and two of my star fellows, trainees, are with me today. So now the teacher is learning from his students. So some of the stuff that you guys are doing are far beyond anything, but it was a wonderful platform. I think just generally, for those that are trying to get into how to manage these patients, we've taken the approach that you want to make these emergencies as elective as possible. And what you really want to do is you want to see whether or not the patients are survivable. You often get these patients transferred from other institutions that are sick, they're intubated, they're septic, they're in renal failure, they're in liver failure, and you just don't know whether or not they're going to survive or not. And I think the approach that not only managing them during the procedure, but trying to get them stabilized before, I think is really important. And techniques of doing that, whatever, and often it requires mechanical circulatory support. So, and you have to kind of figure out what you're comfortable with and what you're familiar with. I think most people know how to do ECMO. Pedro and has taught us a little about LAVA-ECMO. And I think the 5.5 surgical LVAD device is going to be really important. So I think those three kind of have to be in the mix in deciding what sort of support you're going to need. And then I think if you support the patient for a few days, you'll see whether they'll survive or not. Often the renal function improves, liver function definitely improves. And if they wake up, because a lot of times the patients are intubated and obtunded. So you want to see all of that happening in the right direction before you put them through the incredible stuff that is required. And I want all of you to remember that there's going to be a mortality count for all of this is going to be coming down the road, so that your institution is going to be potentially penalized if you do these cases. And so I think just emergency right away doing a case, I don't think is the right thing. I think you have to kind of support them for a bit to see whether they're going to survive. And then the final thing I would say is that you all are going to be living in this new era. We started doing angioplasty. When you create something, when you fix a problem, you usually create two others. So we started doing angioplasty, we had dissection. We started treating dissection with stents, then we had subacute thrombosis, and then restenosis, and then we treat those. So it goes on. And I think the same is going to be with structural heart. You guys are implanting tens of thousands of these implants now every month. And so there's going to be an onslaught of valve failure, and the failure mode is going to be important. So we already see that with the surgical AVRs, but you're going to see a lot of that, and it's going to be really complex. And then a lot of these complex cases, I think, are going to need to be supported. So I do think it's going to be a huge new approach, and you have to be current on what the techniques are, and then try to have it in your institution. There's a team approach. Some people are superb experts at transseptal puncture. You may not be. Some people are experts at transcaval. You may not be. And get the team involved so that you can get a team of experts to help you with the cases. I think that's really it's really nearly impossible for one person to know everything now about structural. And so having a good team with you with lots of combined expertise, I think is really super helpful. So thank you again for letting me join, and I'm sort of thrilled to be involved tonight.
No, thank you for joining us. It's truly an honor and privilege. And for those of you who have joined us, if you have any questions, please put in the Q&A, and I will definitely bring it out during these sessions as we go along for them to be answered by these experts. Dr. Voudris, any thoughts about the use of LAVA-ECMO as early as possible as an early strategy? And I really like the idea. Obviously, as you know,
I do, and I definitely agree. By the way, Gennaro, beautiful cases and a beautiful demonstration of like how much the field has grown and how much we push the limits and every day. So I totally agree with everyone. If we say that we want to be addressing sicker patients, addressing more complex pathologies, we have to be able to do it in a safe way, and not only safe during like before we even start, but also safe during the procedure. There's a lot of unpredictability. Those leaflets can tear at any point. So being able to deliver anything you're planning on delivering in a safe fashion, I think is very important. We know that timing in shock matters. We know that treating it early before like you get all those like high lactates and like late stages and end organ damage makes a difference. So as we've started treating shock patients earlier in coronaries and other heart failure pathologies, we need to do it in valvular disease also. And if that means that we're using LAVA-ECMO, utilizing skills that we have, then we should definitely apply it. So I think it's definitely the future. If we're talking about being able to address what's coming in.
Thank you very much. One of the questions to us before we go to the next presentation is that one of the attendees asked, there's a lot of, as we struggle with the benefit of MCS is in AMI shock. And what is your comments? Because a lot of assumptions are being made of use of MCS in valvular shock. Any takers for your comments on this?
Well, I think this is Bill O'Neill again. I think there's a lot of differentiation between acute MI shock and valve shock. Often in valve shock, the patients are sort of in a persistent low cardiac output, high PA pressure environment with high right-sided pressure. So it's sort of multi-organ failure. With acute MI shock, you don't early on get acute organ failure. If you can get the patients treated within a few hours and adequately supported, they're not going to go into liver failure. They're not going to go into a chronic kidney failure. And so I think that there is a little bit of a different strategy. The valve shock is often more complex because you have a lot of regurgitant lesions, and that may not respond to the way that we usually treat. So using a CP device in these valve shock cases is really not adequate. It just doesn't give you enough forward power, and it doesn't reduce LA pressures enough. So you really have to come up with some stronger hemodynamic support than CP. So I would say that they're very different cases. I think honestly, acute MI shock is a little more easy to handle by a single operator than valve shock because of all the different imaging requirements and CT analysis and that comes with dealing with these complex cases.
Sorry, with that, thank you so much. Dr. O'Neill, would you like to put up your presentations and we'll go into your case on the mitral valve and valvular shock?
Okay, so I was asked to get a mitral valve shock, and I think that this is actually one of Pedro Villablanca's cases, but I was helpful during the procedure and during the care. So I just can't thank and congratulate him. Really incredibly sick young lady, so very survivable. Had a previous mitral valve replacement with a porcine valve. Also has coronary disease, had AFib. She had stage 3 chronic kidney disease and had a previous minor stroke. She presented to an outside hospital, shortness of breath for 3 days. She was in the ER in the outside hospital, was started on norepinephrine, was in refractory pulmonary edema, oliguria, renal failure, and the echo showed a flailed leaflet, a mitral leaflet, surgical leaflet, and she was in fast AFib and she had elevated BNP and lactate. Now, again, the patient was elsewhere for many days, and I think one of the things that we have to work with our own institutions is that when a patient presents in shock, other institutions, they can't wait. And you can't say, well, let's see how the patient does, because the longer they're at the other hospital, the less likely they are to survive. So this is on the left, you can see that the leaflet is really basically flail, and there's a severe wide open mitral regurgitation. So this patient is primarily presenting initially with acute mitral valve insufficiency, and then a sequelae of all of that will cause her dysfunction. So she was in severe biventricular failure. She was on escalating doses of inotropes and vasopressors. She was acute on chronic renal failure and severe pulmonary edema. And so that's what makes this case so challenging. And the longer you wait elsewhere, the more ill they are, the more multi-system organ damage they have, and the difficulty it is to get these patients to survive. So that's why I'm saying that if you could support these patients in some fashion, you may be able to get them some method to figure out whether or not they were going to recover. I think, Pedro, this patient presented to you on a Friday afternoon, so that's a typical Friday afternoon transfer from an acute emergency for the doctor elsewhere that was going home for the weekend. Anyway, so these are the support strategies that we potentially have for dealing with this patient with wide open mitral regurgitation. Now, the ventricle, the left ventricle, is really not that severely impaired here. It's really not pure LV failure. It's just wide open mitral regurgitation. So how can you support the patients? Well, balloon pump is of no value. In the past, we used to have tandem heart, and that actually does work pretty well by decreasing left atrial pressures. An Impella, a 2.5 and a 3.5, just are simply not enough. There's just not enough forward flow, and that's inadequate. So I think you have to kind of think of what you can do in terms of transcatheter approaches, and that would be either the VA ECMO and LAVA-ECMO. VA ECMO in wide open MR in shock will not work in and of itself, because although you do increase blood pressure, you dramatically increase afterload, and you're not doing anything to decongest the pulmonary circulation. So the patients really are not going to be, the blood pressure will be okay, but they'll be in wide open MR, and they'll get lung whiteout, and that's really what's going to cause the demise. So I think in these kind of cases, again, LAVA-ECMO, I think, is a wonderful situation, because you put a catheter in the left atrium, you pull the arterial blood out, and then you mixed it, and then put back the arterial blood in the distal aorta. This will allow decompression of the pulmonary vasculature. And you've seen these cannula before. This is kind of a cool photo that you can see the blood, the red blood on the outside and the blue. So this is really an admixture of arterial and venous blood. Technique, IVUS, ice-guided transeptal puncture. Again, you need to have somebody. If you can't do this, it doesn't mean you shouldn't consider it. Just have one of your partners. And in all the major hospitals with large structural programs, there's tons of expertise now in doing transeptal puncture. So that's kind of one of the minor roadblocks. A catheter is put into the left atrium, and then the machine is started. And this case was further complicated because so you've got a large venous access to go and decongest the left atrium, but you have to put the blood back into the artery. In this particular patient, she had really small femoral vessels, and Pedro thought ahead of time that she's probably going to need support for days. And there's just no way that you're going to be able to have arterial flow down the leg with the large arterial axis. So he actually put in a transcaval device, and then got transcaval access. So the transcaval axis is going to be where the arterial blood is going to go. So you're going to take blood from the left atrium, right atrium, reoxygenate it, and then put it back through. So this is an all venous approach. There's no arterial axis here, nor large bore axis, which is going to make things a lot less complicated. So the LAVA cannula is up in the left atrium, the transcaval cannula. And what happened to the patient is really remarkable. The LA pressure dropped dramatically. Blood pressure was well maintained. LV EDP decreased, and right atrial pressure substantially dropped. Cardiac output went from 3.9 to 9, and cardiac index went up to 5. So this is exactly what you kind of want to see in these patients, is to prove that they have enough hemodynamic reserve so that when you fix the primary lesion, they're going to have a chance of having myocardial recovery. The thing for me that I think is just the most dramatic is how well this decongests normally if this patient was on VA ECMO, you would just see a lung whiteout. And it's because the patient would just have dramatic increases in left atrial pressure. The left atrium is decongested here, and a lot of these patients actually can sit there and not need to be intubated, which again decreases their morbidity. So the patient was considered a surgical risk. I think you have to have a heart team meeting. You have to have the surgeons involved, at least to understand and know the case. But it looked as though now that the patient was able to be stabilized, that they may be able to have a cannula put in. I'm sorry, a mitral valve implant. So this is the diameter of the valve to plan ahead. Actually you can do CT scans on these patients. It's obviously a heroic effort to get the patient in the scanner, but that can be done. And analysis here demonstrated that a 29 valve and valve would work, and that there would be adequate neo-LVOT, so you wouldn't have to worry about the risk of LVOT obstruction when you did the procedure. And this is really fascinating. Remember that the patient had two large venous lines, one in the left atrium and one is a transcaval axis. And so then initially there was a thought about doing a transjugular valve, but that didn't work technically. So it actually was a venous. So there's three large venous sheaths in the IVC, and it seemed like it tolerated it fine. And this is the valve implant. Valve is working very well now. No MR. There was a large VSD because of the septostomy that had to be done for the valve implant, and so the patient had an ASD closure device put in to close on the way out, and now you can see that the valve is working and functioning well. This is the final TE image, shows that the mitral valve is opening and closing nicely. Patient was still quite ill. They tried to wean the ECMO, but she had a low output. So then the transcaval axis was we had we still had some transfemoral 5.0 devices left. Those are gone now, but we used this during this case. And in the CCU, the ejection fraction normalized. The patient was weaned off of support, and pulmonary edema resolved. Finally, the closure was done with Axis. You can see that an ADO2 occluder was used. There was a little bit of leaking afterwards. And in order to really try to finalize things, there was a balloon inflation that was performed. And you can see basically that the entire cannula was closed and there was no residual leak. Follow-up 10 days afterwards showed that the patient was doing quite well with a normal LV function and normal mitral valve function. And she still had a very long convalescence. She had to go on hemodialysis because she didn't recover from her renal failure. She did develop some PE and some ventilatory-associated pneumonia, but ultimately all of this kind of resolved. She was weaned off the ventilator, and then she was transferred to step-down hospital. So that's kind of where we are with these cases. Incredibly complicated. I really congratulate Pedro for doing this amazing case. And it kind of shows where we're going to be going, but it's also kind of incredibly fun to sort of see how these patients 10 years ago we could have never survived, and now we're getting survival on these. So it's incredibly wonderful, and it's a young field for all of you young operators. It's really going to be absolutely fun and exciting to see as you guys progress with this. So thanks very much, Nadira.
Oh, that's a wonderful presentation, Dr. O'Neill. Thank you. Pedro, comments, please.
No, first of all, yeah, I would say I wouldn't be who I am because if it wasn't for Dr. O'Neill, so he's like my adoptive father. So I want to give that compliment online. And you had to have the mentors behind you to make things happen. So this is in part thanks to him. Having said that, I think this was a good case. Some people argue why not the valve immediately. She came with pneumonia, organ failure. We put a valve, gets infected again, so very decompensated. So again, outcomes are important for metrics. Your hospital is looking at them. You don't want to do a dead body. We use here in Detroit a word called TAV or cadaver. Do was a mitral, but you don't want to do a cadaver, put a valve on a cadaver that is just alive because the heart is beating. You want to make sure that these patients are neurologically recovering, organ recovering, because you could do the best valve, but if they're going to stay on ventilators with no brain function, there's no point of doing this. A very good comment that Dr. O'Neill said, this was a mitral leaflet problem, and now it's a surgical. So there's a tendency to use Impella, where I would say Impella has a great indication in ventricular mitral, functional mitral, where the problem is the pump. I have a couple of cases where you have the Impella on P9, and the MR even improves in half of the jet. Then you go down to P2, and the MR open. So I think doing those distinctions about which device fits the patient is key, and having that, as Gennaro mentioned, and Konstantinos also mentioned, saying hi again now that she's here. It's important to on device decision.
And probably Pedro or Dr. O'Neill, like for someone who's starting out and you see these cases, what would be your advice? As one of the attendees was asking for, what are the thought process and the adoption, how to improve the adoption for the use
I
of
think there's a lot of, as you're doing, this is a great podcast now, like education. We're talking about the transeptal, as in major centers you have operators for that, but I think nowadays we train some of our operators to do transeptal now with 3D eyes. Actually, I would say it's a game changer for those that they don't perform any transeptals, because you just have to explain it. They have to understand what is superior and inferior, but it's making things more simpler. Call your mentors, talk to your senior partners, tell them this is what I did. These were great results. I would say in my first case is I used to call Dr. O'Neill all the time. What do you think? What is your suggestion? They've seen everything. They've went through a lot of things. As I said, the fellows, if I'm telling you something, it's because I've seen it or it has happened to me, right? So I think having mentors like him help you a little bit to decide on what is the right thing, and at the same time to innovate, right? To be a little more aggressive. So I think my advice is always look for that person. Call your former mentors from your hospital where you train. Do these podcasts, go to shock meetings, show these cases. I think, LAVA is being exponentially used everywhere now, especially for these cases and, biventricular failure. So I would say this is what we had to do, educate.
That's great. Gennaro.
So actually, let me expand on that, because I was kind of like the perfect example. I brought these techniques that I learned with Pedro and Bill from Henry Ford to an hospital that was not doing these things. So at the beginning, when you bring like a new skill set to a new program, everything like gets in a little bit of skepticism. But if you find the right indication and you do the things that right for the patient, and you have good judgment and you have like good technical skills, I think this is totally achievable. And LAVA-ECMO in particular is not very difficult technically. It really just requires to do a transeptal and a septostomy and send the cannula in the left atrium. So then, to expand on this, the structural operators, they're going to have a more and more critical position within the shock teams. So I think it's very important to get integrated with your colleagues from heart failure, from coronary non-structural, with the ICU, so everybody can understand what you're bringing what level of expertise you're bringing to the table. And you only need a couple of victories, and then you build from them. And obviously, as Pedro said, like be in contact with your mentors and discuss the cases. and you'll see that you're going to be able to implement all of these techniques and strategies. And finally, I want to say, regarding leaflet modification and support, I think support is particularly important for people that have not so many leaflet modification cases under your belt, because the worst thing that you want to do during leaflet modification is to rush. Sometimes the steps don't come fresh of in your head, and then you're not sure if you're not in the right place, what's happening, what's not. When you have the patient on support, you can be calm, and then you can follow step by step, and you can go safely through the entire procedure, no matter how complex it is. So I think, particularly at the beginning, I would rather have a lower threshold to use support rather than a higher threshold. All it does is really adding 15 minutes to the case to get a couple more accesses, but it's gonna pay during the case.
I think that also, I want to compliment Gennaro. I think it's absolutely phenomenal to watch how you developed and how you brought this whole thing to the East Coast. I just want to remind you that the technology is not holding still, and again, really focusing a little bit on the Impella. The 5.5 Impella has truly been a game changer, and I think in particular in severe mitral regurg cases that it may actually be an almost a preferred approach, because you can get access from the subclavian. It goes into the aorta. You get 5.5 liters of flow. There's no hemolysis. There's no sepsis, and the patients even can ambulate with that. So I think that for wide open MR, I think that, and also for VSD, it looks like those two indications, it may actually be helpful. Now, there are going to be new Impella technology, or not new transvalvular technologies. There are already two other companies that are starting trials in the United States using transvalvular microaxial pumps. There are some with expandable sheaths, and there will be transcutaneous pumps available that are going to give up to 6 liters of flow. So just keeping an eye on that, because that's going to be another thing to add to your armamentarium. So I think that it's just really helpful to sort of keep going to these meetings and talk to friends and colleagues, because it is sort of a new discipline. There's no cookbook, and I think each case is a little bit different, but I couldn't tell you more how important it is to sort of figure out your colleagues, what skill sets they have, because some of them have skill sets that you don't. And this is not an ego thing, it's a team thing. And I think you really have to kind of make sure that you got great team members to help you with it. And always make sure that the surgeons are aware of these cases. Okay, it's really, really important, because if a case goes awry and somebody gets PO'd, then the first thing they're going to say is, well, that patient should have just had surgery. And so I think it's really, really important to make sure that they're with you, and they always will, because these patients are sicker than crap, and if they have a surgery, they're going to be lingering in their ICU for 2 or 3 months if they survive. So they don't want to treat these emergency cases.
I just gonna comment something on the questions on the panel. They were saying like some patients do well with VA and balloon pump or Impella versus LAVA. Meaning there's clear room for Impella, as you mentioned, 5.5 and CP. This is more about, we published some data on LAVA versus Impella. City was being review of Impella versus LAVA. There's no difference in mortality in terms of in hospital or short term. The main difference was in vascular complications, which makes sense. You have one arterial access versus two, and there was less hemolysis and bleeding. So, LAVA is not here to replace Impella or the balloon. I think it's here for these scenarios that Gennaro showed, severe AI, primary MR, or in cases where you started with an Impella and you're having bad hemolysis or limb ischemia in the arm. So I think we shouldn't exclude devices like to replace the others. I think they all complement each other, different scenarios, even for the same patient.
Nadira, if I can add one thing, that would be that you should actually start acquiring skills during your routine cases. So actually, your stroke case is not the first case that you should do eye stress echo. Like use it in like your standard, more like scheduled cases, play more time with ice, get familiar with how to do a transeptal on ice. So like keep acquiring skills during the more like routine, like outpatient schedule cases, and then can start up utilizing them during short cases. During short cases, timing is faster. You need to act quicker. Like patients are crashing at a faster pace, so that's not the time to try to figure out how to make things happen. I think like in Pedro cases, I think it's he used multiple different like options of like and multiple different techniques that I think it takes time for someone to like build a confidence level, and that's where like outpatient cases are like a good way to start building up the skill set so you can apply them in a very sick population.
I think that Gennaro made a comment about leaflet modification, and that could be a very good place for people to start learning how to do LAVA-ECMO. And you may not need it, but if you do, the patients develop wide open AI and they'll go into shock in seconds, and you don't have enough time to fix those. So if you put them on LAVA-ECMO prophylactically, then if they develop severe AI, they'll be quite stable during the procedure. So I think that's a perfect kind of a case to start learning how to do it, and you'll be less stressed with the aortic. The lava does not get in the way at all because it's in the left atrium, so there really isn't any problem with mixture with the aortic devices. So that would be a really great place for people to learn how to start to do it.
Well, also for the CTO operators or PCI operators, we just have done recently, a couple of cases, not me, like, Cal, some of the operators I've had before, the last remaining vessel. You're working on the last remaining vessel, elective PCI. That's another case. It doesn't need to be valvular. You could escape from the valvular. But if you want to get us something more stable, it's a good niche as well.
Those are great comments, everyone. Really great advice for all of you out there. And we would like to finish off with a last case. Of course, we cannot forget the not forgotten valve anymore, the tricuspid. So, Dr. Voudris, would you like to share our slides and the interesting case that we had?
Absolutely, and I'm sure Nadira, you remember this case very well. So a little bit different, so more in tricuspid side, so there won't be a lot of LAVA-ECMO here, but it's definitely ECMO involved. So excited to present this case on behalf of the whole structural team at Minneapolis Heart. Young patient, so 48-year-old male, has history of methamphetamine use. He was actually, he presented to an outside hospital in a neighboring state with hypotension, hypoxia. He was found to be on cardiogenic shock with RV failure and severe pulmonary hypertension. While in the ED, he became hypotensive, pulmonary edema, ended up intubated and placed on VA ECMO, and he was subsequently transferred to our institution for further management. This is the presenting echocardiogram to our institution, so you can clearly see torrential, if not wide open TR. You can see like large anatomical gaps and an RV that is hypofunctioning with severe RV dysfunction. What's more concerning is that actually there is associated RV dilation, which kind of give us an idea that this is not something purely acute. There is a substrate of pulmonary hypertension, so there's definitely a chronicity in this tricuspid regurgitation. So he was admitted in our ICU, started on IV remodeling pressures, hemodialysis for volume removal, pretty much tried to remove pulmonary pressures as much as they could, remove as much volume as possible. And despite multiple attempts to wean VA ECMO on high doses of IV remodeling, they've been completely unsuccessful. So at that time, that's by day 6, we do another TE, and you can clearly see why it's impossible to pretty much decannulate this patient. There is still severe RV failure. There is wide open TR. Gaps are still big, so it's pretty evident that the forward flow in this patient is very limited, and that's actually on ECMO. That's on 4 liters of VA ECMO. So high flows of VA ECMO, trying to unload the heart as much as possible, and still significant tricuspid regurgitation. So that's when we got involved and we chatted as a multidisciplinary team, and we're trying to see how we can best help. And what we definitely achieved in the first phase with through diuresis and medication and high flow ECMO is actually bring down the gaps. So you can very nicely see when we first presented, uh, the there was actually a gap in the tricuspid leaflets that was about 2.3 centimeters. And anyone who's doing tricuspid work knows that this is a massive gap. This is not a valve that can be easily repaired. With a lot of work, a lot of high flows and medication, we're able to bring it close to 1 centimeters. So closer to an area where we could potentially work and try to fix that valve. So that's where our clinical challenge stands. So we have torrential tricuspid regurgitation. We have large gaps despite patient being on VA support, dialysis, vasodilators, severe right ventricular dysfunction, possible chronic severe pulmonary hypertension that makes it all a whole picture on a very young patient with extremely high risk for mortality. So we met as a multidisciplinary team, and we thought that this could be a case where we could push a little bit more the envelope, try to see if reducing the TR a little bit could actually improve forward flow, help the patient unload the heart more, and in the long run, be able to bring them closer to decannulation. Issues, so we go into the procedures. The first thing is you're currently on VA ECMO. The venous cannula sits on your right femoral vein, which is most of the times the axis we would like to use in order to be able to navigate our tricuspid valve. On the left side, we have an arterial cannula, which is the return cannula. So we decide to actually move the right femoral vein cannula now into the neck and do a 25 French venous cannula through the right internal jugular vein for our VA ECMO system, which we're very highly dependent on because we really want those gaps to stay as small as possible. So we want a big cannula, high flows in order to minimize our gaps, and then upsize our femoral vein to our 20 French triclip steerable guide. Once we achieve that, this is Nadira's perfect imaging. 3D VCA, you see a 4 centimeter square. It's I don't know, Nadira, I would call it tsunami. I think at this point it's a whole different range. It's like pretty much our strategy is pretty clear. Our target is try to zip as much as we can the valve, try anterior septally. There is some primary pathology in the anterior septal territory. Also, there is a prolapse there. So we thought it's a good strategy to actually try to address the pathology also while respecting the valve. So we orient the cell 3D. You can nicely see the interaction on the left between the TR system and where the ECMO cannula is coming from the right IJ. So you can see we have a nice gap that allows us to navigate safely towards the valve without truly risking any interference with our ECMO. Anterior septal position. We make sure we have nice leaflet grasp, and we confirm that we started getting some reduction in our TR, so we decided to release it. What was confirmed on both views, both our grasping as well as the transgastric view, and you can see nicely as we start zipping the valve, the septal leaflet continues to have a good motion. So we know we still have lots of rooms to go, but we're moving the right direction. So second clip, again, anterior septally. So we're continuing on our zip strategy. Nice leaflet insertion. Make sure we address primary pathology as well. So the prolapse leaflet, you can see it. You can see the transgastric, nice covering, now coming more central anterior septal and bringing those leaflets closer. And we do see a nice reduction in our TR. So there is still severe TR, no question about that, but we feel that there's definitely progress happening, and you see the primary area right now left is that central and sternal posterior septal area. So we actually decided to proceed with a third clip, and that's going to be more central in the posterior septal area, trying to reduce the TR even more if we can. And we're successfully at grasping the leaflets, and we get even more reduction in tricuspid regurgitation. And I think in most patients would definitely consider leaving the clip there, but that's when we start discussing are we doing too much? Are we closing too much of the tricuspid valve? And I can tell at this point, our gradient across the valve is only 2. So you're not really seeing that increased gradient, but as you can see the beautiful imaging by Nadira, like you can very nicely see that RV now starts to struggle. So we're still on ECMO and we know we're not going to see the full effect. So we slow down a little bit on our flows. And you see the RV is not happy anymore. And given the history of the severe tricuspid, is the severe pulmonary hypertension, we're worried that we're just creating extra pressure to that RV. So we decided to remove the third clip. We did leave severe tricuspid regurgitation behind, massive reduction in the 3D VCA. You can see from 4 centimeters squared to 1.05. So significant reduction. Patient stayed on ECMO after the procedure, and he was actually weaned off pressures and decannulated 2 days after the procedure. We're able to discharge him home on post-procedure day 6, and then 30 days, he still remains asymptomatic on pulmonary hypertension medications. So this is a discharge echocardiogram, and what's impressive is actually you can see now the RV, even the RV size starts to decrease, better RV systolic function, still severe TR, but definitely something the patient can tolerate. And we're actually giving more venting to the RV and more room to the RV to vent, so it's not struggling as much. So tricuspid regurgitation reduction can be beneficial in select patients with cardiogenic shock and right ventricular failure. This is a completely untested area. Those patients were excluded from all clinical trials, so we don't have a lot of data on tricuspid repair or transcatheter repair on patients in shock and with severe RV failure and severe pulmonary hypertension. So this has to be a very select cases. And most importantly, use any device and any support you have in order to minimize gaps and be able to get the best result possible. So up titrating ECMO flows, you saw we went from 2 centimeters gaps to actually 1 centimeter, which made a case possible. And it can actually improve the chances of successful grasp and successful repair. Thank you.
Thank you, Voudris, for the beautiful presentation. It's really a team effort for this patient. And I remember saying to everybody in the room, we are not getting perfection for this patient. I truly believe cutting the TR by just half would really help the patient. And really put my mindset that I think TR quantification during cases really important to really see the good outcomes. And what really surprised me, Dr. O'Neill, Gennaro, and Pedro, that it was our surgeon who actually at the bedside in ICU where we increased the pump flow and we did the TE repeat and we saw that reduction of TR. And that's when I remember calling Voudris to say, I think we should do this to try and save him. And it worked. Any thoughts, Dr. O'Neill, Pedro, Gennaro?
I think this is a very good case for taking out the TR, which was a great intervention. But I think there are some very key points that we learn on the wrong way with some cases. So let me start saying first, I wouldn't replace this case in shock. And the reason is, you replace this case, you tank that RV. And I had one case was different, wasn't revoked, was a valve in ring, biventricular shock. I did a PVL of the mitral. And then the valve in ring, I thought, oh, I'm going to get a home run. I'm going to replace this. The moment I replaced this, that RV tank, but it wasn't, okay, another RV tank, milrinone. If you have PE pressure, I pressurize so much the pulmonary tree that that patient have uncontrolled you want to call it like bleeding through his trachea. We congested his lungs in retrograde. So I think the decision on repairing is good. Some comments that Dr. Neil can comment later about you could use other devices like Arpella, which is now from the neck smoothly as any other device, Protect Duo. But what you did, guys, on not achieving the home run was key. That's I think this is the lesson from that case. You're just bridging this patient for a recovery. And the examples of the images of how the RV was kind of starting to tank with the third one, I think it's a great case, achieve the outcome, which is reduction, get some RV relief, and then good case the way you guys manage it. But I think that's to me the key point in terms of the intervention.
Yeah. I mean, if I can add one thing, I agree with Pedro. It's like that RV would not have tolerated any elimination of TR. Like it's a severely dilated RV. It's definitely there's a component of chronicity there. I think, and even just bringing it below severe TR is actually you could see the RV started to struggle. So it was a strategy more of like address primary pathology, increase forward flow, and pretty much get him as a bridge to decannulation and pulmonary hypertension treatment and further steps down the road.
Yeah, I think it's a wonderful case, Voudris. Congratulations. I'm really impressed by your technical expertise at being able to grab those leaflets with those huge gaps. That's remarkable. So really, congratulations. It's interesting in this case what the ECMO does because ECMO is going to increase arterial pressure. I don't know what it does intraventricular. And that would be quite interesting to look at because I think it's possible that it was increasing pulmonary vascular resistance. And that's why when you started to put the third clip in, the patient had such a profound increase in PVR that it just really couldn't go forward, had forward blood flow. So then basically it just stops. I think that when you're dealing these patients with severe RV dysfunction, it's really crucial to take a look at what vasopressors they're on. Alpha agonists are just incredibly harmful because they dramatically increase pulmonary vascular resistance. And the last thing a right ventricle needs is an increase in PVR. So I think that trying to get them off of those alpha agonists and onto something like milrinone may actually be quite useful. We don't know about using the Impella RP or the RP Flex because there just hasn't been enough. I mean, I think it'd be interesting to see what happens to the flow. So it's an unknown. I think somebody's going to have to look at that when you have a patient that crumps when you're doing an RV procedure to see if the shock will be improved. It should improve because you're sending flow across the pulmonary valve and into the pulmonary arteries, and hopefully decongesting RV. But it's again, I think is an unknown. So lots of interesting stuff, and I agree with Pedro that and Nadira that not hitting a home run was a home run.
Yes, and one of the questions live actually ask for, Voudris, do we remember the hemodynamics associated pre and post clips? I can't remember from the top of my head.
So we have initial hemodynamics and we have final. We cannot transduce the TriClip. Actually, the guide, unlike the mitral, does not allow for a real-time gradient. So you can take them after the clip is deployed, but we can find them. Like I'm sure I don't know.
I can tell you something, not this case, of course, but about one of my partners and friends, Brian O'Neill. I think the paper is accepted or being published soon. So we do right heart cath pre and post on every patient. We do a TR intervention. And the main reason is I'm seeing all these questions. I think there's a lot of unknowns. We don't know. We see a third of patients talking about the MR, that the MR got worse, and then it didn't change in some of them improved. So I think, my advice is just as and having Dr. O'Neill here, who's the father of hemodynamics, if you ask me, having a swan gas on these patients pre and post is key. Not for survival, just to decisions. As you decided on the ECMO based on the swan, I guess, that's why you do it. But I think predictors about recovery, what we're seeing is, PVR is a good determinant about, is this more of the lung problem or the RV and the TR and the PA pressures. The cutoff of most of the trials was 70. Have we done patients above 70? Yes, and some of them actually recover. So I think there's still a lot of unknowns, and that's why I think we have to keep, doing science and and publishing. You guys have a great tier experience in Minneapolis, so it would be great if you guys to show your experience in terms of hemodynamic as well for T tier. So yeah, that's a comment I wanted to make.
We will. Absolutely would love to collaborate with you. And, I know we are at the top of the hour, but any last comments from each of you, well, before we wrapped it up for all our attendees?
I just want to conclude. I showed that slide at the beginning of the hour showing the intersection between the three spheres, which is understanding hemodynamics, heart function, delivery large bore access, master large bore access, and delivery therapy. And Konstantinos, your case was just like a perfect demonstration. It was like understanding the hemodynamics. You had to switch the ECMO cannula from the groin to the neck, and then you found your way to then deliver like tricuspid valve repair. So I think like that's why like the field of valvular shock is like so entertaining and interesting in some ways, because like you really have to combine all this skill set. And yeah, great session.
Keep up the good work, Nadira. This is fantastic. I totally enjoyed it, and I think it's a great way to educate our peers on the new stuff that you can't read about in the books or even in recent articles. I mean, this is absolutely phenomenal. Congratulations.
Thank you so much, Dr. O'Neill, Dr. Voudris, Dr. Villablanca, and Dr. Giustino. I mean, we will definitely have you back for Valvular Shock Part 2. I can certainly think of that with more interesting cases. And before we end, just would like to also let everybody know that we have the 10-year anniversary of CVI in 2026. The date of the conference is August 6 to 8 in Denver. So please look out for emails and also in our website. With that, thank you so much, everyone, for joining us for a wonderful 1 hour. I thoroughly learned a lot, and I hope you guys too. Thank you so much.